Hi everyone, this is M.B.B.S nerd, and in this video I'll be talking about lymphoplasmacytic lymphoma. So let's begin. So lymphoplasmacytic lymphoma is a B cell neoplasm presenting in the 6th or the 7th decade, and the cell of origin is a lymphoplasmacyte. Now most commonly there is secretion of monoclonal IgM, and this leads to a hyperviscosity syndrome, also called Waldenstrom macroglobulinemia. Now macroglobulin stands for IgM, and there is no bony destruction or renal failure or amyloidosis seen in this, because basically bone destruction is due to those plasma cells which claw onto the bone marrow for growth factors. So renal failure is not seen because there is no excretion of light chain, and obviously the amyloidosis also is not there because of that. Now if I talk about the pathogenesis of this lymphoma, so if you see the B cell here, so the B cell receptor binds to an antigen basically, and this leads to the activation of this protein called M.B.B.S, which leads to the increased signaling of nuclear transcription factor, which in turn causes the survival and proliferation of this lymphoplasmacyte or B cell. So if there are mutations in M.B.B.S, this leads to the increased signaling of the nuclear transcription factor, which promotes the growth and survival of these lymphoplasmacytes. So this is a normal process which occurs in the stimulation of antigen, but due to mutation, it happens all the time, and this leads to the malignancy. Now if I talk about the clinical features, then the patient here presents with weakness, fatigue and weight loss, and half the patients present with lymphadenopathy, hepatomegaly or splenomegaly, and anemia is there due to the marrow infiltration by these lymphoplasmacytes. Also there is one interesting thing, that about 10% of the patients have autoimmune hemolytic anemia, because there is production of these IgM autoantibodies against our own RBCs, which causes the hemolysis of these RBCs. I will talk more about this anemia when I start the topic of anemia. Now, due to the increased secretion of monoclonal IgM in the blood, there is hyperviscosity, or you can say the thickening of the blood, which causes it to be, have this stasis, because whenever the blood becomes thicker, it has decreased mobility or flow. The fluidity decreases and there is more stasis. That is why this leads to visual impairment due to venous congestion of renal veins. Also, there are many neurological problems because of inadequate perfusion by this viscous blood, and this leads to the headache, dizziness and deafness. Also the cryoglobulinemia is seen. Cryoglobulin stands for this IgM only, because this IgM precipitates at low temperature. That is why we see this cryoglobulinemia, due to the precipitation of macroglobulins at low temperature. If I talk about the cellular morphology, then there are large lymphoid cells are seen. Basically, if we take a bone marrow aspirate, then we get large lymphoid cells with vesicular chromatin. You can see in this picture that there is vesicular chromatin, because these cells are transcriptionally very active. That is why we are having vesicular or loose chromatin, and there is prominent nucleoli. Also, there are Russell bodies, as we have seen in plasma cells in the cytoplasm, and also there are Dutcher bodies which are seen intranuclearly. Infiltration of nerve roots, meninges and brain can be seen, but it is very rare. Also, if we do the immunophenotyping for these type of cells, then we see that it is positive for CD20 and surface immunoglobulin M, and this helps us to differentiate that okay, this is a lymphoplasmacytic lymphoma. So these are the diagnostic markers for lymphoplasmacytic lymphoma. So I'm ending my video today. If you like this video, give a thumbs up, comment on the comment section, and please subscribe. If you want more such videos coming in, I will see you in the next video. Till then, bye bye.